Shawn Remacle comes to us as the Director of U.S. Provider Solutions for Microsoft and Life Sciences. He's based in Virginia and really is responsible in his current role with Microsoft for shaping strategy and vision for the U.S. public market. Prior to this particular role, Shawn was employed with West Care as the CIO. We are very pleased to have all of our keynotes, and at this time, please welcome Shawn.
Thank you to the New Jersey, Delaware Valley HIMSS members for having me here today. I really appreciate the opportunity. I'd like to start this presentation about health reform with a quick show of hands because we're going to circle back around to this at the end of the presentation, so I don't have to look out through these lights. So how many in here, and I kind of think I know the answer, but how many people in here are actively working with implementing EMRs or getting to meaningful use in this current time frame? Pretty much everybody, except probably the vendors. And that's the next question is how many people are actively working from an IT perspective around health reform initiatives for their member organizations? Wow, not bad. Last presentation I did had about 200 people and there was one hand who had worked on health reform. So I guess the folks in the Northeast are much more active. So some of this may be familiar with you all depending on what you're working on. For those of you who are not participating in health reform, we'll go through it and you'll get a little sense for what has come out of Washington, D.C., which is where I live and work, and some of the folks that run our lives, if you will, from the government standpoint, how they view health reform. That was, okay, you know, let's go. Let's try it this way. Okay, so our agenda today is we're going to talk a little bit about some of the forces that are driving health reform, especially from the government perspective and how their thinking is. We'll dive into just a very few of the most, the most financial impact for providers, especially in terms of health reform, value-based purchasing, readmission rates, and then hospital-acquired conditions. Last little bit is I'll kind of tie back into, I spent a lot of time mentoring friends who are CIOs or who are younger in the organization, try to help them through. And one of the things that when I meet with customers quite a lot, we talk about the financial responsibility of the CIO to be involved with the organization, not just from the IT perspective as a utility, but also IT as a strategic lever. And then we'll talk a little bit about what some of our friends in Washington think is next in line for the changes in health reform. So do a quick level set here. These slides are not going to build the way I wanted to, so I can see that already. We'll just go with that, with the way it is. So when you look at the stimulus package, the main drivers matters was really a chunk of money for the government to get jobs, improve spending, and of course in yours world, that's mostly involved around the incentives that you've seen for getting to health IT and EMRs, but there's also funding for health information exchanges, regional extension centers, you know, large chunks of money for the VA and CMS and those people as well. When it comes to reform, it's more around quality, equity of care. Of course, the big things that were in the news when we went through this process about a year and a half ago was all about health insurance and exchange and getting people into the system, access and stuff, and we'll talk a little bit about that as well. So really, from the government perspective, one was really about jobs and stimulating the economy and kind of moving forward from our perspective in health world, health IT. And then the reform part is really kind of enabling CMS really to have levers to kind of push on the traditional things that they do, which is lowering reimbursement for providers, which tends to be the trend that as long as I've worked in healthcare, that's never changed. And had a discussion last night with the folks at dinner, don't see it changing anytime in the future, so it'll just be more of the same. So there's three forces that when you talk to the folks who developed the health reform bills, you talk to CMS, the things that they're trying to get towards are access, quality, and cost. So we'll delve into that a little bit for each one of these. So when it comes to access, I think the one that's probably the most on the radar screen for everyone was the change in terms of getting people, the uninsured, onto some type of insurance exchanges or some type of support for insurance. That's actually a good thing for most providers, depending on how you work your reimbursement and how your hospital's set up. I have a lot of friends who, the CEOs, basically have decided that reimbursement in their hospital, everything that they do, they will try to live on Medicare reimbursement, no matter what their payer mix is, right? Because this is going to be a continuous issue for them. The number of unemployed or the number of people who are marginally insured will continue to grow. Second thing here is about trying to maintain the system. So there's some incentives for employer plans. Of course, they're trying to prop up Medicaid quite. There's a lot of investment in that. There's obviously a large reorientation around prevention, value, and quality, trying to raise the bar on those areas constantly. And then the last thing is there's the market incentives for consumers to engage in the healthcare system. Clearly, there's a lot of discussion about that now in terms of the individual mandate and all the things that go with that. But the idea of the government at the time that they passed the bill was to make sure that they get folks involved in the process, get into insurance. Quality, obviously, is a big player here. You see it especially in the things that I'll talk about later on today. You have meaningful use, which all of you have raised your hand or are already working towards. The idea that there's certain quality measures that are valuable in terms of the processes. There's also transparency now, and that's been going on for a little while in terms of the CMS core measures and hospital compare and the government initiatives about making sure that quality information at least is transparent to the consumer. We can argue whether that's actually working or not, but at least you can say that consumers have an opportunity to engage in what's going on in terms of the accuracy of the data. The government's running that. Explosion of quality measures. Anyone who's working in a hospital has seen this. Continues to grow. The number of measures. Private payers are adding on their measures as well. And now we have the whole population health measures that are starting to roll out in terms of ACOs, bundled payments, and the things that go on in around that setting will drive even more quality measures across populations. And then lastly, there's a big drive to pay for quality, right, and pay for performance. Bundled payments, reductions in reimbursements, and those type of endeavors. And the last driver is, of course, the big one. I think 18, 19% of GDP in the United States is healthcare. So cost is always a driver for the government. It's probably in every conversation every day, whether it's being budget deficits, you name it, money is going to come up into play. Healthcare is going to be one of the top issues that they're going to go after. At the time that the health reform bill came out, we were in a nice recession, a little bit maybe in a historical recession in terms of the last 100 years. And certainly that drove a lot of what happened in terms of how the health reform bill was created and driven, especially by the Democrats. There's actually a lot, if you look at some of the states that we work in, at least myself and I talk with folks at state and local governments, a lot of pressure in some areas. A lot of folks are really struggling with how they're going to handle Medicaid at the state level and provide insurance coverage in those areas. And a lot of states are doing really large cutbacks. Some of you in this area, I'm not sure about what it looks like in this area, but I know out west it's pretty ugly. Healthcare costs continue to outstrip the economic growth of this country. Having worked in a hospital and having been a CIO, I'm always fond of saying money goes through the hospital, doesn't actually stay there, because most of you are, your pay, the benefits that you have are not dissimilar to other people in the community. A lot of that money goes to other vendors and stuff that supply materials. They're not regulated, if you will, by the government. So I certainly can appreciate that. But healthcare in total, the government looks at it, the growth is beyond their capability to stay up with it. More and more, my conversations used to be with healthcare customers. More and more of my conversations are with employers. Although, if you look at kind of the origination of healthcare coverage, insurance and coverage in this country, it really came out of employers creating benefit plans to attract the workers back in the 40s and 50s. That was what it's based on. That's still kind of its origination in this country, even after Medicare's come on board. But employers are now starting to get in line with the idea that they are really going to have to actively manage this problem because it's really cutting into their costs. Even my company, Microsoft, which has an excellent healthcare plan, is radically changing to address this issue with employees. And most of our employees are younger than I'm 52. Most of them are younger than me, but we have a large healthcare issue that we're trying to deal with as well with 90,000 employees. And the last one here is that CMS regulatory intent is very clear. Everything that you look at in the bill around health reform is around getting to pay for performance or pay for quality. And you'll see that continue to grow. I don't think you'll see any slacking on that. Current proposals are even to stretch this even further. So when we look at healthcare, a lot of folks in IT especially don't really get the sense for what does poor quality mean in terms of the institution I work for. Given the raise of hands, most of you are probably pretty well plugged into this, but for those who aren't, I'll just go ahead and cover it. For the patient, and I've actually unfortunately been through this, almost lost my ex-wife to a blood infection. So mistakes can actually lead to death, dismemberment, all kinds of ugly things, longer length of stays. For example, I'll give my own personal story here. Went in, had a simple, well, I shouldn't say simple, craniectomy, brain surgery, but simple for me, right? But that was a fairly easy procedure. She had a genetic malformation, had to fix it. Unfortunately, I was asleep in the room. I stayed in the rooms. I understand the idea of making sure that patients stay safe. I fell asleep. Nurse came in the middle of the night to take the drip out, didn't wash her hands. Next day, we had a massive blood infection, and my ex-wife got to stay in the hospital an extra 82 days. And guess who paid for that? I did. And the insurance company. I got to pay the 20%. So it has an impact, right, on patients. It didn't bankrupt me, but it sure didn't feel good there for a while. And she was not happy either. So the finances, I mean, there's a cost of rework, right? There's now with the last couple of years, there's never events, right? Uncompensated care, surgeons who leave things inside folks or operate on the wrong shoulder or eye, whatever they're doing, those are no longer compensated. So there's a cost to the hospital and the institution. And now, we'll talk about this much more later on, there's actually greater risk of reduced reimbursements across the whole entire population for the hospital. It does impact staff. When a hospital has poor quality, it's fairly well known. It gets talked about. You have joint commission reviews that don't go so well. People are getting, and so it tends to lower the overall morale. And if there's actually choice in your community about where you can work, some folks will move to a better institution because it does weigh on folks. And then there's also the fighting fire syndrome. You're always being reactive, not proactive. So your processes are out of control. Your quality's out of control. That someone next to you is not doing the right thing, there's not enough training, whatever, those things actually have an impact on staff. And then lastly, from the CEO and executive suite level, when you're focusing on fires, there's no strategic capacity. You don't have any chance to sit down and figure out where do we want to be as a company and move past these issues. It's always a fighting fires strategy. So we'll delve into each of these a little bit, these system reforms a little bit, and talk a little bit in depth about what I see from my conversations with customers mostly, okay? So when we go around the country, I'm fortunate, we have some very innovative customers, and I think this is like the typical health IT bell curve. We have people who are extremely innovative and doing wonderful things, and we have people who are, and health IT tends to be a laggard anyway, and there's people who are actually in the Stone Age. When I went to my hospital system, 3 hospitals in North Carolina in 1998, I met the Stone Age. I worked for a Fortune 500. I came in, no internet, no email, and the only systems they had running were running on AS400. And there was a pile of cables this high in the data center room. So I actually felt like I had made a horrible career move, but it did give opportunity to make changes. We did get there. But so some of you, if you work in that environment, I feel sorry for you. Good luck to you. When I had to read all the 1,980 pages that are the health reform bill and kind of pull out what the impact is on provider, we kind of boil the ocean down into these. The ones in red we'll talk about a little bit more in depth today. They did change the way the RAC program works at the bottom around the regulatory oversight, so more focused now on Medicaid and in additions to the Medicare. So those are not new. Most of you have probably been going through RAC audits. You may or may not have participated in from a knowledge management perspective, but we won't cover that today, okay? Not enough time. So value-based purchasing. So what's kind of driving this? You've been reporting on quality for some time, 21 measures. And CMS is constantly, signaling that they're going to really move towards this pay performance environment across the board. So the idea that we have fee for service and moving towards pay for performance is really where CMS wants to go. It will take them a long period of time, but that they're certainly signaling that. In AHRQ's world, poor quality has big cost. I won't read these to you, but $420 billion gets the attention of the government. We can debate whether all that's real or not, but there's probably a large chunk of it is very real. There's like my ex-wife, and those things actually do happen to patients all the time. So this is the actual regulation kind of condensed. We don't have all the sections and subparts and all that. We kind of rolled it up here. But at the end of the day, value-based purchasing, the move from pay for reporting, which folks were doing, to pay for performance. And as we get into 2013, we start to see actual reductions around reimbursements. And this is significant in the sense that you can be rewarded for quality as well. I saw a report this morning that I was reading right before I came in here. And I would quote it if I could remember who wrote it. It was a quick verbiage I saw this morning. The prediction was that 75% of hospitals will lose money under value-based purchasing, at least in the first 2 to 5 years. And the average expectation was that the average hospital would lose $1 to $2 million in a 5-year period of time. Some will lose up to $16 million. We'll talk about that a little bit later. Because someone's going to win in this game and someone's going to lose, more than likely. The bad thing about value-based purchasing, it ramps up, and it does affect all Medicare inpatient DRGs ultimately. For those of you who work in a non-acute care facility, rehab hospitals, inpatient psych, things like that, welcome to pay for reporting, but you'll soon be on pay for performance as well. It's in the code. So you will now be joining the process of gathering information, reporting it to the government, and getting paid less for it in the future. I'm not going to read this and go through it. This is kind of for me, a distillation of what our customers are doing, some of them are more progressive ones. And so what I'm going to do is give you kind of one story that one of our customers is doing, and I'll put it to the CMS core measures. They have an EMR. They have one of the better EMRs. They paid lots of commas and zeros for that EMR. And it does great things for them. And they have a data warehouse, and they do some great reporting after the fact. But what they didn't have is they got into getting ready for value-based purchasing and the whole quality measures was that they had scorecards for their executives. But it was all, if you will, as they cleaned autopsy work. You're looking at things retrospectively, 30 days after it happened. You're pulling abstract data together and trying to figure it out. When you move to pay for performance, things have to happen much more in real time. So I'll give you one example that they use. So in one of the CMS core measures, you have to give an antibiotic to a patient who's diagnosed with pneumonia within 6 hours, right? So today, that's the macro indicator, right? So that's laying out here in the green section. I'm reporting on that. But downstream of that, there's all kinds of downstream indicators that have to be monitored to actually make sure you capture that money in the future. So did the physician and then write a prescription, put it in the, you have CPOE, put it into the pharmacy system, or maybe today paper-based, nurse puts it into the system. Did that order get looked at and filled in the pharmacy? Did it get back to the unit where the drug was ordered, and it get delivered to the patient? So if you take it just that little level, there's a whole bunch of downstream indicators that have to get done in order for the macro indicator to get met. So what these folks did is they started to pull data from their real-time systems, their EMR, their wonderful EMR. They pulled it into third-party applications, and they start to look at it in real time. They start measuring those downstream indicators, and they built thresholds around it. So for example, if the pharmacies had it for X amount of time, right? So now we're at the 4-hour threshold, 2 hours left before we don't make it, then they start to escalate. It goes to the pharmacy manager, maybe it goes to the COO, maybe eventually goes to the chief nurse officer, wherever it needs to go. Things will get escalated through emails, text alerts, phone calls, whatever. They have automated all that into their system. So there's a rules-based engine, if you will, that's running this. The EMR can take pieces of that and do well, but it's not really good at escalation and finding the next person in line who needs to do something. And at the end, what they do that's really interesting, this particular issue, they found that they had a major problem. They go back and do their quality improvement, they do their Pareto charts and see where the problem is. The problem was in third shift of pharmacy. Not enough staff. So they can fix the problem. So not only can you see what's going on in real time, you have the opportunity to go back later on and see where your problems are and continue to fix your process. Because really, value-based purchasing is about reducing process variation, right? Can IT help in that? Absolutely. Is your EMR part of the story? It is part of the story, but we find with most of our customers, they struggle with getting all the things that they need and all these indicators and all the ones that the private payers and others are giving them to consolidate it at one area and have it make it be actionable. that somebody will do something before the clock ticks off, okay? So next we'll talk about readmission rates. This is one that I probably spend most of my time with customers. Had a great conversation with a large worldwide company yesterday who's looking at managing probably almost 400,000 patients from a post-discharge perspective. It's also one that's also very near and dear to employers and to health plans. You know, I've seen a lot of articles recently about the value of readmission rates. Is it a good indicator? It's probably not the greatest indicator of health, but as I said last night at dinner, I had an opportunity to speak to my congressman. I used to live in North Carolina. We were having this discussion about health reform. I was a big advocate for access. So you can't legislate people to be doctors and nurses. You know, you're shrinking the base. You know, how do you get that back? We had that long conversation. And we got into the conversation about pursuit of happiness. And so when we had the conversation about someone with congestive heart failure going home and eating a bunch of hot dogs, the answer the congressman says, if I need to squeeze money out of the system, I can squeeze physicians and hospitals. But I'm not going to do something that's going to make the voters do something because they have pursuit of happiness. So eat as many hot dogs as you like. The problem is you're taking money out of the hospitals, where I used to work, for behavior that the individuals, all of us, choose for our health, right? So it comes back to, is readmissions really the best indicator, or is it just an indicator of poor decisions by all of us and how we determine our health, right? We're overweight, we don't take our blood pressure medicine this morning because you're in a hurry to get to a presentation like me. You make mistakes, right? It might cost you. So readmissions, you know, from the terms of CMS, as you can see, 1 out of 5 discharged patients return within the hospital within 30 days. And of course, the government looked at this again from a cost perspective down here at the bottom. There's a large chunk of money tied up into improving quality. So again, from the regulatory standpoint, beginning in fiscal year 2013, there starts to be reductions in Medicare payments. Probably the big one here is the bottom bullet. Reductions we apply to all Medicare discharges. So if your payer mix is 50% Medicare and you're above that threshold and you're not doing well, you'll have a reduction against all those Medicare discharges, okay? That could be a big financial impact. We'll get to that later. So the conversation that we tend to get into, and again, trying to distill this down, conversations with customers when we look at readmission rates, it's really about the pre and post-discharge process. That's where most of the work's going on now. From the pre-discharge standpoint, you know, today, you know, we may term them frequent flyers. We may actually have some processes where, depending on your setting, nurses in the ED go, you know, you might know you by on a first name basis, right? But in reality, in a larger institution where people have multiple choices within the community where they can end up and go, you may not be able to have great visibility into what's going on with folks who are coming into the hospital. And you're really probably not looking at root causes and so on and so forth. And then also, once the patient discharges, traditionally, hospitals just look at what goes on inside the 4 walls, right? That's your business. In fact, your hospital systems, right, are based on episodic care, which drives billing. What do you do when you have to start managing people outside the 4 walls? It's non-episodic care, and they're going to start sending you data. Where does that go, right? So what a lot of our customers are doing, they're kind of looking at risk mitigation. Before the patient discharges, they want to have a clear look at who's most likely to come in. They might opt them into programs, centers of excellence, right, for diabetes or asthma or those other kind of type of chronic conditions. They're trying to understand if this is a frequent flyer. Maybe they're going to have a nurse call more often. So if you will, it's sort of separating the wheat from the chaff, right? You have a whole bunch of people that are going to discharge. Who are the ones who are the most likely at risk? And you're going to apply those limited resources that you have, and they'll get more limited over time goes on. How do you apply those to the problem? And we'll show a few examples of what customers are doing. And then on the post-discharge side, and the work that I probably spend 50% of my time on now, is how do we actually get patients to opt into programs, do self-reporting of data so that we get a vision into what are they doing in the home setting. And not that they tell me they ate 5 hot dogs, but can you stand on a scale, and I see that you gained weight, you have congestive heart failure, I want you to come in and see the outpatient clinic. A cheaper cost transaction rather than the high readmission inside the hospital. Avoiding readmissions really will from a risk mitigation standpoint. So this is an actual screen capture from one of our customers in Washington, D.C. They actually built a view. If you really, we come back to this as an example of real-time data. So they have, this is a real blend of their data warehouse and their EMR into this third-party system. And so what does it look like? So, you know, in red here at the top of the scale, we have, they've looked at 500,000 patients, whittled down 38 indicators that they believe will be most predictive for a readmit. Won't read them all here. You can see some of them here. They make sense, right? You have your frequent flyer. And then down at the bottom, we have someone who has a lot less chance of readmit. Statistically, anybody can come back. What they're trying to do is look at this patient, make sure they have the right medications. Do we need to make sure we have the right follow-up? Do we need to put them in a program? How often are we going to call them once they discharge? So on and so forth, right? So it's just utilizing resources the most effectively as possible. On the post-discharge side, the coordination of care, at least from Microsoft's perspective, some of the customers that I work with, most of the work that we do is around taking this information that's in your EMR, we discharge a patient, we now load it into what we call post-discharge databases, right? Managing patients non-episodically, not trying to drive billing. We don't look at the data as clinical credibility, right? Someone sends me a blood glucose reading by text message. It's not, it may be fat-fingered, it could be a mistake, they could not understand what the reading is, but the way the clinicians in these institutions that we work with look at it is it's better than not having any visibility into what's going on in the home setting, right? Especially for challenged patients. So we find one of our customers, Denver Health, uses text messaging quite extensively. Their population is largely indigent, prepaid cell phones. And they actually encourage their patients, sometimes they actually give out prepaid cell phone cards to keep in contact. One of the best stories I got out of Denver Health, my favorite stories is how this works. Homeless man, has no home, lives in shelter, but he wants to control his diabetes. It has a major impact on his life. He's a frequent flyer in the emergency room. He actually opted into this program, carries around a prepaid cell phone. He gets messages every day. They gave him a free glucometer, checks his blood every day, sends in his reports, and now he's under control. This man doesn't even have a home, okay? So I have people, when I go to meet with them, say, this will never work. My patients are geriatric, pediatric, do this. It works with indigent populations. It'll work most of them. Is it going to be 100% universal? No, of course not. This is about, you know, kind of whittling down populations, right? We have folks who are doing it with text. We have folks who are doing it with voice. We have folks who use a personal health record. I'm going to show a quick video of one of our customers who does that. We have multiple methodologies that our customers are using. They're really creating feedback loops. Send a couple messages. So for congestive heart failure, typical messages are like, experience shortness of breath today? Did you gain some weight today? Did you stand on a scale? What did you weigh? And they'll compare it to what the last readings were. And did you take your medications today? That's 3 questions. And you can imagine if any of those questions are not answered correctly, they'll make the recommendation, it'll go flow into a work queue for a case manager. Case manager will look at it and evaluate it. Instead of looking at, one of my customers, unfortunately, is a public health institution that's doing quite poorly. They're in the news. They're probably going to go bankrupt. Well, they are bankrupt, but they're a public institution, so they can't go anywhere. They have about 3 case managers for 6,000 diabetics. So you've got to figure out who's in trouble here. So when they look at their queue in the morning, they try to pick out the 30, 40 who are having trouble and not call the 5,000 who are doing okay today, right? So I'm going to show a quick video. Hopefully it'll run here. We tested it. This is the last one is around home monitoring. If you notice in this presentation, I'm not talking about Microsoft products or what Microsoft is doing specifically. So my caveat on this one video, there is a mention of a Microsoft product. Here's the good news. It's a free product. It's available to you. Software development kit's free. The software is free. So this is not a sales process. I make no money selling free products. So that's my caveat here. So this is about Partners Healthcare in Boston, Massachusetts. The thing I want you to take away from the video, these are the clinical directors speaking. Think about in terms of some of the themes that I laid out here about managing large populations and reducing readmits. Okay, you'll hear some key points in here.
Chronic illness is growing at an alarming rate.
These are illnesses, diabetes, hypertension, heart disease. No one is cured of. You really do have to manage this illness over a lifetime once you have been diagnosed.
We don't have enough hospital space, office space, doctors to take care of all the need that exists out there.
So how do we provide that kind of primary care through other types of delivery systems.
Partners Healthcare Center for Connected Health helps doctors and patients by creating technology solutions that manage chronic illness more effectively and efficiently.
That's really what Connected Health does. Enable a care provider to take care of many people continuously rather than get them for a small slice once every 3 months.
Partners Healthcare has about 50,000 employees, and about 6,000 of those are doctors. And those doctors work in our academic medical centers like Massachusetts General Hospital and Brigham and Women's Hospital, teaching affiliates of the Harvard Medical School. And its geographic reach is in the New England area.
I was diagnosed with diabetes in October of 2007. It was shortly after that I began participating in the Connected Health program. My ultimate goal was to establish a diet that consisted of those things that had little or no effect on my blood sugar readings. The internet-based program was really helpful to me because it made it easy to record the readings and upload them into something where I could view them this month, this week, 3 months.
They take the device over to the computer and they plug the device into the USB slot, and then from there the data flows up into the Health Vault data store, and that's when it becomes actionable for us. That's when we can access it and pull it back in and do that automated coaching and the feedback loops and all that rich experience that will drive hopefully better patient behavior.
It was very easy for me to navigate the system. No problem whatsoever.
Tools like this help practices that are struggling with manpower issues and have a large burden of illness to have data in about real time, which is the key to success in managing illness.
So Connected Health Care Suite is really a platform built on the Microsoft technology stack. And what it does is enables us to take data from multiple different kinds of devices, bring that data in, apply rules to it, and then present it to a patient, present it to a provider.
The Connected Health Care Suite gets access both as a software and as a service. The patient is uploading their remotely monitored data, they're looking at their graphs, it becomes their tool that they're using. We have outside organizations that want to gain access to some of the information that we gather. And when we do that, we don't have to provide the entire experience anymore.
Software plus services is the glue that makes the Connected Health Care Suite work for our patients.
The baby boom generation is a generation that is used to being mobile. They're inquisitive, demanding. They're going to be looking for solutions to help them better manage their care over time. So tools like this give them that ability. It means better outcomes for people that have diabetes or hypertension or heart disease.
We've shown now in 2 different studies that we were able to lower the readmission rate to the hospital after discharge by about 50%.
I absolutely believe that participating in the Connected Health program has helped me manage my condition. For me personally, it's been marvelous.
So this is just one aspect of managing patients at home, okay? This is not a home health program necessarily, for those of you who don't have home health agencies. It's also part of a strategy. This particular customer is using Health Vault in terms of, you saw, they wanted better clinical credibility. They want the devices to be read. I will say this from a personal standpoint, most of the customers I work with indigent patients, low income populations. University of Miami, we work with Overtown patients. 70% of the people in Overtown have diabetes. And for those of you who are old enough, I lived in Miami actually during the time of 1980s when we had the riots in Overtown and Liberty City. It's a hard scrabble area, very, very oppressed area, very difficult area to live in. But the folks at University of Miami mostly do charity care. That's pretty much what they do in this community. And Dr. Schwartz uses personal health record. The City of Miami actually donated old refurbished computers to patients, and they can actually plug in their information. But they also have instant messaging, so they can go back and forth to triage nurses and ask questions. So they look at it as a holistic view of trying to stay in touch with patients in the home setting. Okay, so it's mix and match. It's what's best for your particular population and disease states that you're trying to monitor. And the last one I'll cover kind of quickly because it gets to be a little repetitive is hospital-acquired conditions. In this particular example, I'm talking about hospital-acquired infections, not conditions, but there's obviously a whole list, and there's a list on the next page I'll talk about. Again, we kind of led off with this with a personal example. Maybe you all have some as well. But it does lead to, unfortunately, quite a bit of death. You can see the top 4 HIAs. And also, from the terms of CMS, again, large opportunity to improve quality and reduce cost. So here is the 11 items that are part of a hospital-acquired condition. I'm definitely not going to cover all these. But what I want to leave you with is the same idea. Make improvement in these quality along these areas. If not, there's going to be a reduction in reimbursement. That's the bottom line. So each of the ones we've talked about today all have a common theme. Improve quality. If not, if you're above the threshold, you'll be having reimbursement cut across the board. And there we have it right there. To kind of shorten this up a little bit and finish on time, I'm going to give you a screenshot of one of our customers. This is an academic medical center in the Northeast. And again, it comes back to the idea this actual group has been around for a long time. They actually built their own EMR. So they have a large programming team and can actually develop anything they really want to build. A little rare in today's world, but there's still some out there. And so this is their ICU, one of the screens they use in their ICU, which were their nurses and their physicians. And when they had a big emphasis on reducing sepsis. They actually looked at the Surviving Sepsis campaign. They looked at the bundled treatments and then the protocols. They built them into their system. So they took information from lab, right? So they're looking at like serum lactate, white blood counts. They're looking at their bedside monitor, so they're looking at O2 saturation and blood pressure and all those things, right? And they bring all those data in. They wrote some algorithms, very simple little tool. They actually collect data from nurses. Nurses observe things that are not necessarily built in the system. And unfortunately, sometimes when nurses document and physicians document, it's just big blobs of data. It's really not actionable. You can't get the pieces of discrete data out that you were looking for. So they actually built some forms where there's check boxes that give them indications about what's going on. So they pull these 3 areas together, and they build a simple system in the ICU of red, yellows, and greens. Who's at risk for sepsis, right? And who's already in a sepsis state, and are we following the right bundled protocol? So if the protocol says, vasodilators and oxygen and all, whatever the protocol is, are those things being followed? So you see as we go from left to right, here's who's at risk, here's how we're doing, and they keep track of it. They had a major reduction in the number of deaths due to sepsis in their ICU, critical condition. It's just one example of bringing multiple sets of data into dashboard scorecards and making actual data out of it. So the last one, we're kind of work back around from our original conversation of who's working on meaningful use and who's working on health reform. This crowd's a little bit more even than the last ones I've talked to. One of the benefits of having been a CIO for a long time and working on different advisory committees for different vendors and actually even working at Microsoft now, I get to see my friends as I travel around the country, catch back up with them, and we have kind of these conversations with their executives. And they're kind enough to share with me their view of where they are at with both things we talked about today, meaningful use and getting to their EMR. This particular customer is in the middle of an EMR implementation for a large hospital in Ohio. And this is one of his smaller hospitals. He decided to share data with me. And we also looked at it from the health reform side. So this will look probably familiar to you. He gave me the data, we pumped it in, kind of looked at what his incentives was going to be, right? So at the end of the day, he's spending probably around $12, $15 million for this hospital to put in a system, and he's going to get 1 point, if he attests early, and that's the key here for him, most of the money's in the first year, right? So he's going to test early and try and receive some of the incentives, right? This is a task that his CEO has for him. This is something he works on, like most of you all in here. The other side of it is, so when we talk to this customer about health reform, they have some committees, right? Chief nurse officers looking at readmission rates, quality officers looking at some of these value-based purchasing initiatives. They never really sat down and thought about what their risk is. Well, the good news is for me, as now I'm a salesperson, is I can go online, look at the government's data, and I can tell you who's a customer who's at risk, so my conversations fit really well now. And this particular friend of mine and his CEO, we had a conversation that they're lousy at every quality initiative, okay? And their mortality rate's not so hot either, okay? When we look at what their exposure is, right, the worst case scenario for them and their revenue streams and their Medicare risk, they have a huge risk. So what that leaves me with is, and for the folks in the room who didn't raise their hand that you're plugged into health reform, or maybe even marginally so. Here's kind of my net sum when I talk with customers, and here's what I'll leave you with is EMR implementations and the pursuit of meaningful use, those are really important steps in building foundations of really getting to some of the things that we talk about in health reform. Getting to improve your quality, reducing variation and process variation. IT is really critical to that. It's the business perspective of IT in a healthcare setting. And the ARA EMR incentives certainly help you offset some of the costs of your EMR implementation. Although with some of the prices of some systems I've seen, you're not even get close to helping in that regard. But the health reform legislation, some of the things that I covered today, have a much larger financial impact on your hospital and may impact people are working at the hospital or whether the hospital exists at all. I mean, there's already tons of consolidation in the industry. This will only drive it further. Those who can't keep up, those who can't make the investments to improve quality and bring IT to the table to make it work will run a risk. There's a huge amount of money at risk here. And the downside of that was, whereas the financial incentives last this long, the health reform ones last, you can just throw infinity at them, and there'll be more of them, not less of them. So it'll only get worse. So I look at it from terms of revenue protection. Is a big lever, right? It's not about you're going to get more money. In value-based purchasing, you can potentially get a little bit more money, but for the most part, you're trying to protect the revenue that you have, right? And that's the conversation that, you know, if you work for a chief financial officer or a chief executive officer, you're part of the team. Those are the conversations where how IT can be plugged in. And I'll leave you with this. This is the last slide. So Washington never sleeps, never stops discussing. Partisanship never goes away. And it has an impact on what we do, and it has an impact on the things that we talked about today. So most of you know that the whole PAPACA is up for grabs anyway around the individual mandate. Florida, Virginia have already went through this. Virginia just recently, through appeals, kind of got thrown out, but it was on a technicality, right? I put it in here for those of you who are in. Basically, you can't sue the government until you actually pay the government. That's the way they wrote it. So you're arguing about an individual mandate that's never been paid. So Virginia will be back. Okay, once someone makes a payment on an individual mandate. And then we had big deficit reduction. We got a couple senators sitting in a room, they're hashing it out. I guarantee you, we've already had some insight into this, that the whole incentive program around EMRs, all the money that's being thrown out there, it's on the table. Because they can scale that back. What are you gonna do about it? You know, give your EMR back to Epic, Cerner, and probably not. It's not gonna happen. They're probably not taking it back anyway. So that's on the table. So all these incentives that we talk about may actually get reduced, cut, may have tighter time limits on them. And the last thing is, healthcare being such a big part of what we do, Democrat, Republican, every 2 years, new House of Representatives, every 4 years, new president, so on and so forth. That will have a cycle on how these things change. The one thing I think you pretty much count on, because universally talking to legislative folks about this, quality and reducing reimbursements, they're going to keep that, because that's an end game for them. They continue to squeeze the neck of providers and doctors. Giving out more incentives, probably not on the table going out forward, okay? So with that, that's kind of my presentation about health reform. Hope you got a little education out of it, and I thank you for your time. Thanks, Steve.